This should be recording, right? All right. And just before we start, I'll give a quick bio of Dr. Chin and then let her have the talk. So Dr. Chin is an OBGYN, assistant clinical professor and global health lead in the Department of OBGYN at Mcmaster University. She is a PI for UBC's Global Surgery Lab and the content consultant for their Essential Surgical Skills curriculum. She's currently completing a master's in global surgical care at UBC and recently returned from Angola, where she underwent training in the repair of obstetric fistula about, I think, 2 weeks ago. So we're very happy to have her. Now she's in Canada. She completed medical school and residency at Mcmaster University and is active in teaching and curriculum development at the Michael G. DeGroote School of Medicine, which is the Mcmaster School of Medicine for anyone who's not familiar with that. Her interest in global surgery stems from clinical experience in Rwanda, Uganda, Guatemala, Angola, and Zimbabwe. Her areas of interest include obstetric fistula, which we'll learn a lot about tonight, and medical surgical education and capacity building. So without further ado, I'll let Dr. Chin share her slides and present them to you. I hope you enjoyed the talk.
Thank you so much, Marshad. Thanks for those kind words. So good evening, everyone. Good afternoon, good morning, depending on where you're joining us from. Thank you for making the time out of your busy schedules to be here. It's such a privilege to speak with you today. I'm just going to put my slides up now on the screen. Maybe Marshad, Isabel, and Sarah, since I can see you, if you can give me a thumbs up when you can see the slides, that'd be fantastic. Excellent. All right. And then as we had mentioned just at the very beginning, if you have any questions, feel free to just pop them in the chat. Rashad will monitor that for me. And if there's anything really pressing, he can interrupt me. But otherwise, we're going to do a Q&A session at the very end. So this is a brief outline for what we're going to be talking about together. I'm going to just present a very brief overview of how I got to where I am. And then we'll launch into obstetric fistula. So the who, what, where, how, and why. And we'll talk about what it's like to live with fistula, barriers to getting a fistula repair, why fistula care overall is inaccessible, and then looking towards the future of fistula care work. What are the gaps and what can be done about that? And then I'll end off with a brief overview of what I'm currently doing in the field. I have no disclosures or any potential conflicts of interest. So I thought we would start off with a quick walkthrough of how I got to where I am. So I remember as a trainee, I was ever curious about how staff people did it, meaning how they did global surgery. So I thought it'd be nice to provide a little bit of background. Of course, this isn't a prescription. Hopefully it's just a bit more of an inspiration to see one way that you can do global surgery, because there are just so many ways that you can incorporate it into your career at every single stage. So I started medical school at Mcmaster in 2007. And those of you that are familiar with Mcmaster's curriculum will know that the summer after the first year of med school is typically blocked off for electives. And I spent the vast majority of my time in a town called Kabale in Uganda. So it's in the southwest part of the country, just by the Rwandan border. And then I went across the border and spent the remainder of my time at Shira Hospital, which is up in the mountains of that part of Rwanda, which is adjacent to the border with the DRC. At that hospital, within the first 2 days, I remember witnessing 3 emergency cesarean sections, and 2 of those babies ended up being stillborn. So if any of you have been at a cesarean section, no matter in a high-income country or a low-income country, for the most part, the moments after baby is born are usually sort of abuzz with activity. The pediatrics team or the nurses that are taking care of the baby are off on the side assessing the baby's crying. The obstetrics team is doing their thing, dealing with placenta. There's usually suction noise, anesthesias over on that side with their machines beeping. So there's this whole buzz of activity. In stark contrast, these cesarean sections, I remember, there was just this somber silence. And the only sound I could hear behind me was the puff of the ambu bag as the nurses were trying desperately to resuscitate these babies. And so even in those very nascent early days of my training, I remember being stunned by this. And so after witnessing these deliveries and then also some maternal mortality, I decided to shift my career aspirations from neurosurgery and cardiac surgery, which were the initial plans when I started medical school, to obstetrics and gynecology. And the hope was that as an OB-GYN, I could work somehow to address maternal mortality and morbidity in these low resource settings. One other anecdote stands out in my mind from this hospital. So that picture on the far left shows the entrance to the maternity ward at Shira Hospital. And typically, I would be able to hazard a guess as to how many laboring patients we had, judging by the number of partners sort of pacing up and down these steps. And I remember one very peculiar sight. I saw about 20 young men standing there, except they all seemed to know each other. And so I hurriedly greeted them, Wanamutse and Kinya Rwanda, and then hurried up the steps into the maternity ward to talk to the nurses. And without my even having to ask, they said, oh, they all carried her in on a stretcher from the village. She's been fully dilated since before they left the village. And it's a 12-hour walk. So they didn't want her to have to do that all on her own. So they took turns carrying her. We quickly assessed her, diagnosed her with obstructed labor, underwent a cesarean section, and fortunately, mom and baby were fine. But that certainly brings to mind the question as to whether or not the outcome would have been the same if her family and friends hadn't carried her and hadn't expedited her presentation on that day. And so even with that happy ending of this anecdote, there's a sense of all of the potential or existing infrastructure gaps that exist in low and middle income countries, which we'll touch on shortly when we talk about obstetric fistula. So by 2009, I had entered that rite of passage that every Canadian medical student goes through, which is known as CARMS, the Residency Application and Matching Process. Like any final year medical student, I was deathly afraid of going unmatched. And I toyed with this idea that maybe, I should hide my interest in global surgery. I knew it could be divisive, especially back then. And maybe, just maybe, if I had hid all of my plans, I'd be, a more generally appealing applicant. In hindsight, I'm glad that I decided against that. And instead, I put my global surgery plans front and center in my personal essay. And I think that not only helped to select for the programs that were not turned off by my global surgery interest, but it also selected for those that would be actively supportive in my pursuit of this passion and of this professional development. And Mcmaster ended up being that place for me both then and now. Fast forward to 2012, where I was an R2. And as any junior surgical resident will tell you, you're doing 1 in 4 call, you're incredibly busy. So it's pretty difficult to schedule an elective or to ask to be off call for that elective. But as luck would have it, I had scheduled an elective with a preceptor in rural Ontario, and he had just been invited to go to Guatemala on a surgical trip. So with the blessing of my program director and also CMPA, I booked a ticket and we were off to Coboco, which is about 4.5 hours from Guatemala City, up in the mountains, mostly inhabited by the indigenous Achimaya people. The cases we did were predominantly urogyny, lots of pelvic organ prolapse, uteruses that were sitting outside the body, basically, incontinence procedures and the like. And then by R3, the tail end of R3, I had a bit more elective time. And again, with the support of my program director, as well as the graciousness of my co-residents in covering my off-call time, I went to CEML, which is the hospital I just returned from last month in Angola. There, I worked with Dr. Priscilla Cummings, who is a Brazilian American OB-GYN, who taught me all the Portuguese that I know. But it was with her that I also first saw a patient living with fistula, and also first assessed someone and learned how to do the beginnings of a fistula repair. But with her, we also saw pretty difficult cases, and one stands out in my mind. So we were at a hospital in Shulu, which is a very rural, remote place, accessible only by Cessna plane. And one morning, we went around the antenatal ward with our portable ultrasound machine. And this one particular patient had been admitted with antepartum hemorrhage, and the uterus was at about the level of the umbilicus, so say roughly 20 weeks. However, when we placed the ultrasound on, we saw this. So the lower image there shows that classic snowstorm appearance, which tells us that there's been overproliferation of the placental tissue or cells in keeping with a molar pregnancy. The ovaries were also grossly enlarged, like 12, 13 centimeters each, with fecal lutein cysts. The trouble was that this wasn't just a normal, complete molar pregnancy. She also had lung metastases, and she was in acute thyroid storm. And so this was actually more so a gestational trophoblastic neoplasia. So typically the treatment here would be aspiration and curettage. So you need the aspirator, so the little suction curette, to be able to clear out the contents of the uterus. Only had a sharp curette. And the trouble with the sharp curette is that you could run into significant intraoperative bleeding or postoperative bleeding. And this was our blood bank situation. So I still remember a very patchy, chopped up Skype call where I was walking around the compound with my laptop looking for the best signal as I tried to call back to Hamilton to one of our gynae oncologists, Dr. Lori Ellett, who happens to be on this call tonight. She just happened to be awake at 4 a.m. Hamilton time because that was when she would go to the gym. So I spoke with her, and upon her recommendation, we decided that the best course for this patient was in fact to perform an open total abdominal hysterectomy, bilateral salpingo oophorectomy. So taking out the uterus, cervix, tubes, and ovaries. Fortunately, this patient had already had 3 living children, and this was going to be the safest route for her. I also had some funding from this travel fellowship grant that I was on. So we were hoping to also then use these funds to send her to the nearest big center where she would hopefully then also get chemotherapy. By 2017, I was an OB-GYN and ended up spending some time at Karanda Hospital in rural Zimbabwe. Now, I know you're all here for the clinical pictures, but I thought I'd make an exception here. So as you can see, we brought our then 2.5-year-old daughter, and we did life on this rural hospital compound, trading off responsibilities as a dual physician couple between work and home. So in addition, of course, to all the clinical cases, one of the biggest lessons I learned on that trip was how to balance the home and the hospital life in a setting where we had no support network whatsoever and were very, very isolated. And those of you that have read my musings on global surgery will know that I feel pretty strongly about having candid discussions about balancing the unique challenges of balancing professional and personal lives in the setting of global surgery work, which is obviously a whole other talk in and of itself and beyond the scope of what we're going to discuss today. So I'll just leave that little crumb there. So that was how it started. Despite all of these various clinical experiences in low and middle income countries, I still felt that I lacked that broader systems level understanding of issues that underpin many global surgery conditions. And as we'll discuss in the context of obstetric fistula, surgery is but one piece of the puzzle, albeit very important. And so there's so many upstream and downstream considerations ranging from the social, the cultural, economic, government policy, NGO funding, program monitoring and evaluation, research, advocacy. So for me to get a better grasp of this milieu, I started looking for graduate level degrees to try to bridge this gap in my knowledge. And that's how I came upon and started the UBC Masters of Global Surgical Care. I really like the fact that it targeted mostly working healthcare professionals, and it had a very global surgery focus, unlike many of the other programs and degrees out there, which have a very broad global health bent. So during this rigorous course of study, I finally started getting this grasp of this complex interweaving of various factors at play, particularly when it comes to formation and management of fistula. But then it dawned on me that I still needed to bridge another gap in my knowledge, and that was in how to repair obstetric fistula. But before I get into that and my current work, let's take a little detour and talk about obstetric fistula. So we know that fistula is a communication between any 2 epithelialized surfaces. Obstetric fistula is a type of genital fistula, which is then a hole between either the urethra or bladder or ureter or rectum and the vagina or cervix or uterus. So obstetric fistula then can classically be your vesicovaginal fistula between the vagina and the bladder, a rectovaginal fistula between the rectum and the vagina, or anything in between, depending on which two organs are connected. So when someone thinks about obstetric fistula, they often think about this, the classic simple vesicovaginal fistula. But the truth is, obstetric fistula can be very heterogeneous, and we'll see shortly how heterogeneous it gets. So this classic obstetric fistula, and I've denoted all of the fistula with blue dots as if we're doing methylene blue dye test together, okay? So this fistula is usually pretty easy to identify, either on inspection or by palpation. There's a divot and it's pretty obvious where it is. Here's the sagittal section between, and you can see the connected to the vagina here. You can have, however, more complicated vesicovaginal fistula, which are more difficult to identify. So this one here, a corner fistula, often you cannot see just by pure inspection, and you cannot identify even by manual or vaginal exam. You can't feel the divot. Often this will require installation of methylene blue so that you can then see the tiny little trickle of blue from the corner. And this corner fistula is usually tucked right up against the pubic bone. And it's usually due from a previous fistula repair that just has broken down and then led to yet another defect. And then it can get even more complicated. So this circumferential vesicovaginal fistula, on vaginal exam, you'll actually be able to feel the pubic bone because that entire lower part of the bladder is totally gone. Or you can have a vesicocervical or a vesicouterine fistula, where you have a connection between the bladder and the cervix or the lower part of the uterus. And you can also have a ureterovaginal fistula. So this classically happens at the time of cesarean hysterectomy, where inadvertently the ureter has been either tied off or cut off. And so you can see in this very distal part of the ureter here, it's quite stenosed because it's been cut, and then the proximal part of the ureter is very dilated because of that obstruction. And I've actually seen this lead to renal compromise as a result. So how does this all happen? Well, 90 to 92% of genital fistula are felt to be related to childbirth. When we use the term obstetric fistula, we're classically referring to the type that results from obstructed labor. So meaning labor that goes on for days and days, like we're talking 3-5 days, and there's no access to definitive delivery, which is usually cesarean section. The constant propelling from the contractions of the baby's head down into the pelvis then puts pressure on the maternal tissues. The tissues die off, and then the fistula forms. And unfortunately, in 90 to 95% of cases, the babies also die. This is another diagram from the FIGO fistula manual. I know there's lots of writing, but just the key here is to look at the pink area. So again, you can see between the baby's head is applying significant pressure onto this tissue here, right against the mom's sacrum. Same thing here, the bladder is completely distended and is not able to empty because of the pressure from the baby's head onto the pubic bone. So that is the classic obstructed labor leading to obstetric fistula. Another obstetric cause would be those that cause the iatrogenic fistulas. So these are all the non-obstructed labor causes. So things like C-sections, cesarean hysterectomies, some operative vaginal deliveries like forceps vacuum, and then sometimes some episiotomy. So when you cut the pubic bone as a last-ditch effort to deliver the baby in the setting of a really bad shoulder dystocia. Just a quick note there, for the obstetric causes, the terminology can be used a little bit loosely depending on what article or what source you're reading. So sometimes they're used interchangeably, but really the take-home point here is that the obstetric fistula refer to the obstructed labor types, and usually iatrogenic fistula refer to the non-obstructed labor, like the C-section, C-HIT types. Okay, and then as you can see in the chart, there are all these other non-obstetric causes for fistula. So iatrogenic from gynae procedures, so usually hysterectomy, from trauma, including female genital cutting, malignancy in low and middle income countries. Classically, we're talking about advanced cervical cancer, from post-radiation, other intravaginal practices, so including Gishiri cutting. So that is a form of female genital cutting that is commonly performed by the peoples of the Hausa and Fulani regions. So that's in northern Nigeria or southern Niger. And it's done for a variety of ailments. So things like dyspareunia or infertility or pelvic organ prolapse or incontinence. And the gishiri refers to the long knife that traders used to use to cut off blocks of salt. And so they use a very similar knife, insert it in the vagina, and then make cuts along the anterior vaginal wall. So you can see how that can lead, obviously, to fistula. Other causes, non-obstetric causes of fistula would be things like inflammatory conditions like IBS or Crohn's, and various infectious causes. So you can see there the asterisked etiologies are the ones that are a bit more common in the high income setting. So up until about 100 years ago, obstetric fistula actually did exist here in North America, which is where I think most people tonight are calling from. So this is the Waldorf Astoria Hotel in New York City. And this is on the site of the last standing fistula hospital in North America. And this was closed, or that hospital rather was closed in 1895 because of decreasing case numbers. So that's just a reminder to us that really obstetric fistula did in fact exist here and it was present, but it was also successfully eradicated because of increased access to safe obstetrical care. These days, obstetrical fistula typically exists in sub-Saharan Africa and in Asia. There are various estimates in terms of how many people are affected by obstetric fistula. The most commonly cited ones are up to 2 million people worldwide, and about 50,000 to 100,000 new cases per year. The one trouble is that the population that lives with obstetric fistula is often very difficult to reach. So they're usually in rural or remote areas. And then secondly, they live in isolation and under a lot of stigma. And so it's often very difficult to adequately count these cases. They're usually underreported or they remain undiagnosed. And then in terms of answering the question as to why fistula occurs, really we need to understand that a whole number of factors and events will coalesce together to create obstetric fistula. And so even before the person gets pregnant, there's this background that sets the stage for a less developed pelvis that then leads to a higher risk of obstructed labor. So often there's significant poverty, and because of the poverty, there's pretty significant malnutrition. So that leads to a less developed pelvis. Because of poverty, there may not be money for school fees. And so the girls might be taken out of school. And that's, of course, on a background where in many of these societies, education and schooling for girls is not really the norm. And that, of course, increased school attrition for girls is also tied to earlier age at marriage and at first pregnancy. And then also at baseline culturally, it may be the norm for 10-year-olds, 12-year-olds to get married and then get pregnant quite quickly. And so all of that then increases the baseline risk of obstructed labor. And then when that individual finally does get pregnant, there are a number of infrastructure barriers to them getting antenatal care, so in the pregnancy, and then also intrapartum care, so in labor. Typically, these folks don't have access to a trained birth attendant to attend their labor. And so if there is obstructed labor, that might remain undiagnosed or just there's a delayed presentation because of that. But even earlier in the pregnancy, there may not be antenatal care to identify, say, a larger baby, a macrosomic fetus who would be at risk for obstructed labor, or even say a fetus with abnormalities like hydrocephalus, so a larger head that would be at higher risk of obstructed labor. And then even in labor, there are what we call the 3 delays. So Thaddeus and Main in 1994 wrote this paper that everybody cites now. Initially, the 3 delays were cited to describe the issues at play for maternal mortality, but it applies here as well. So let's say the person is in obstructed labor. There may be delays to seek care due to social or cultural factors. So for example, in many of these societies, the male relative needs to give permission for the person to go and get healthcare. So it might be the husband, the brother, the younger male cousin, the uncle, the grandfather, whoever. Let's say they do get permission to go seek care. There may still be delays in reaching the care because maybe it's rainy season and the roads are washed out. Maybe there's only a bicycle to get to the nearest healthcare center. Maybe you have to hike for 12 hours like the lady in Rwanda, that sort of thing. And then let's say the person actually does reach the healthcare facility. Even at the facility, there may be delays. So there may not be adequate equipment. There may not be adequately sterile equipment. There may not be someone who's trained in providing safe anesthesia. in which case sometimes cesarean sections are done under local anesthetic, which I've seen. There may not be a provider trained in recognizing the obstructed labor that then requires cesarean section, or there may not be a provider trained in providing a safe cesarean section. So many of these factors accumulate, and that all then results in the obstructed labor either not being recognized or not being addressed promptly enough, and so the fistula forms. So we can see then, and this is just a distillation of these many factors, that fistula are unique in that their existence is really primarily driven by all of these external factors that are completely out of the victim's control, right? Poverty, malnutrition, lack of education, child marriage, lack of agency, which is tied to gender equality, lack of access to reliable contraceptives that might delay that first age or that age at first pregnancy, absence of antenatal intrapartum care, transport issues, healthcare infrastructure barriers. So really, there's little that an adolescent or a reproductive age person in this situation can do to reduce their personal risk of obstructed labor and thereby fistula. So if the fistula forms, then that person is constantly leaking urine and feces. They may have other components of what we call the obstetric fistula injury complex, including foot drop, and that's because of an L5-S1 spinal nerve root damage. Because they're constantly leaking urine and feces, will often smell, and so that'll drive people away, and they're usually abandoned, divorced by their spouses. Their families, extended families will leave them, their villages will kick them out. So then they live in isolation. And they also lose economic viability. So if you're leaking urine and feces, people aren't going to be as inclined to buy vegetables from you at the market as they normally would. Your breadwinning spouse may have left you. And so these patients spend most of their waking hours tending to the washing and drying of their soiled linens and other hygiene matters. And so some people live like this for up to even 30 or 40 years in isolation before they're able to get care. So we can see then that although fistula aren't inherently life-threatening, although some patients tell me it's a different form of death for them, this perpetual urinary and fecal incontinence really is more than that. It leads to this huge cascade of social, economic, psychological consequences that render it a significant disability that not only interferes with this person's quality of life, but it can also alter their life trajectory. And that also has ramifications for their families. So sometimes there are living children who are then abandoned and are parentless and orphans. Also the communities and the countries that they live in which these people live are also affected by these downstream effects. So the natural next question, especially as a surgeon, is then, well, why can't we just repair it, right? Like there's a fistula, let's just go ahead and repair them, and that would be great. So the thing is, right now, only 1 in 50 patients get their obstetric fistula repaired. In other words, 49 out of 50 people live with obstetric fistula. And there are a number of reasons as to why this is the case, but really we can distill it down to about 3 main themes. The first is stigma. So in many of these communities and societies, there are traditional belief systems that attribute the fistula to infidelity, usually on the woman's part, witchcraft, a curse, or some other thing that the patient is to be blamed for. The isolation also makes it really hard for these patients to seek care, right? They can't harness the usual social networks to find out about care. So let's say the UNFPA has a camp coming through in 2 weeks. They may not know about that because they're living completely by themselves. Or let's say the nearest hospital has hired someone who's able to repair fistula. They also don't know about that because they're completely ostracized. And then finally, the biggest one is that the fact that care is currently not very accessible. So let's explore that a little bit more. There are a few reasons for why care is inaccessible. The first is that most fistula hospitals are in large urban centers. So again, thinking back to some of the factors and determinants of obstetric fistula, most of those patients live in very rural or remote areas, and hence they didn't have access to the healthcare in the first place. And so that's already a long, arduous trek at baseline. And then you factor in maybe some language barrier, if there's some regional language differences. And then on top of that, you're leaking urine or feces. So you're really not going to want to get onto a public bus while you're doing that. So it makes that journey, pretty much prohibitive. The cases themselves are very long, they're complicated, they're quite heterogeneous, and they're very poorly remunerated. And so we'll see shortly that there's a high attrition rate for surgeons who even know how to perform fistula repair. And the other thing to keep in mind is that most of these patients cannot pay out of pocket because they are impoverished. And so fistula repairs are often funded by organizations like Fistula Foundation or by private donors. There's also a paucity of data on training. So we don't really have good numbers and good data to back up those numbers as to how many cases someone needs to do or how many years they need to train to achieve competence in fistula repairs. And then finally, fistula are sort of in this unique paradigm in global surgery. So if you think about other surgical procedures, let's say cesarean section, cholecystectomy, appendectomy, I'll pick on my ortho colleagues, ORIF, or cleft lip and palate, right? There's usually a decent pool in high-income countries of folks who know how to perform those procedures and can, go and teach and increase capacity. The issue with obstetric fistula is that it's virtually non-existent in high-income countries. And so that same pool of expertise is also non-existent. When we talk about capacity building, it's usually more in the context of what we call like South-South collaboration. Now, specifically from an OB/GYN standpoint, I certainly did not come out of residency knowing how to repair fistula because we just simply don't have the pathology. Some gynae residents and some urology residents will go on to complete like a Urogynae fellowship, or the official name is the Female Pelvic Medicine and Reconstruction Surgery Fellowships. However, the American accreditation body only requires that they complete 2 before they finish the fellowship. And again, keeping in mind that the etiologies for fistula in a high income setting are very different than the ones in the low income setting or lower middle income setting. So then with that, we're starting to see some of the gaps in fistula care, which really looking forward should be the focus of future work. So the other way to think of these gaps is to picture fistula care on a continuum. And although we talk a lot about the surgery and doing the surgery to treat it, really it starts with prevention. So it starts with having access, reliable access to good, high quality obstetric care, including the antenatal, so while you're still pregnant, and also the intrapartum, the in-labor care. And so this is in an effort to decrease the formation of new cases while you're also repairing the existing cases. So in the era of the Millennium Development Goals, which ended in 2015, we saw that global expansion of obstetric care and emergency obstetric services does actually work, right? The maternal mortality ratio decreased by 45% between 1990 and 2013. However, it's not just an issue of providing cesarean sections. They need to be safe cesarean sections that are by adequately trained people. And so in countries like Ethiopia, where there has been significant improvement in obstetric services, we're actually now starting to see a change in the profile of obstetric fistula. So instead of the classic obstructed labor type fistula, which is actually decreasing in proportion, we're now seeing an increased proportion of the high iatrogenic fistula from a cesarean section that's gone wrong. And so we need to ensure that the cesarean sections that we're mounting to prevent fistula, obstetric fistula, are not inadvertently causing these iatrogenic fistula. The second step in this continuum is, of course, fistula repair. So the actual surgery to treat it. And when we talk about fistula repair, there's sort of 2 main considerations. The first is training, and the second is maintenance of those skills. So when it comes to training, FIGO back in 2011 came up with a fistula surgery training manual, and they launched that curriculum in 2012. Even so, we still have a paucity of data, as I alluded to earlier. We don't know how long it really takes someone to achieve competence. They do stratify it based on complexity of repair, but we still don't have good numbers based on that stratification. Moreover, we don't have data stratified based on what that person's training background is. So are they starting as an associate clinician, meaning like a medical officer who usually has about 2 years of general training after medical school? Are they a urologist, a general surgeon, an OB/GYN? So we don't have any of that data. Also, we have to remember that fistula are not only heterogeneous, but the spectrum of complexity is huge. So we talked about the simple fistula and sort of the intermediate types, but it goes all the way up to and including things like doing a mains pouch, which is a urinary diversion procedure where you're putting the ureters and implanting them into the colon, or you're doing things like rotational flaps or autologous flaps. So naturally, it's going to take even longer for someone to achieve, that expertise and to develop this repertoire of cases. And then when it comes to maintenance, even for those who do manage to, attain this expertise and are comfortable repairing simple and maybe complex fistula, there are very high rates of attrition for these surgeons. So this article by Gondway and Maharaj in 2019 looked at healthcare providers in Malawi that were providing fistula repair and fistula care in general. And they cited a number of barriers. So the first is that, as we talked about earlier, the cases are poorly remunerated, they're long and they're difficult. So there's no compelling reason for them to do this instead of the millions of other cases and patients they need to take care of. There's also a shortage of staff trained in fistula repair, specifically the complex repairs. There's low morale overall. The salaries are low, the working conditions are poor, they're overwhelming. They're just by the sheer volume of patients that need to be seen. And then finally, the infrastructure and supplies are lacking. So they talk about things like the power cuts out intermittently. There's not enough safe, clean water. They have to share it with the fistula patients who are using it for their linens. They have to wait hours for the autoclave to be ready for the next cycle to prepare instruments for them, and so on and so forth. The third step in the fistula care continuum is that of reintegration. So after someone undergoes a repair, there is still much to be done, right? Obstetric fistula care is holistic. It's not just the surgery. In the weeks that follow, they need to learn catheter care, colostomy care. There need to be multiple methylene blue tests to make sure that they're dry. And even more than that, there's significant psychological trauma for most of these patients. And so there's lots of work around doing that psychological therapy. For a lot of patients as well, there's literacy skill and teaching. There might be skills training, entrepreneurial mentoring, and an effort to hopefully facilitate their reintegration into their communities or to forge a new life after they move on from the fistula center. Now, specialized fistula hospitals like Hamlin Fistula in Addis Ababa, which many people have heard of, have access to a decent amount of funds and also human resources to provide these very comprehensive, amazing programs. But in the setting of a general hospital, where fistula care is but one of a whole slate of competing priorities and procedures, it's often very challenging to dedicate the people as well as the infrastructure to solely fistula care, and also to create these, extensive community-based rehabilitation and reintegration programs. Another challenge when it comes to the rehab and reintegration is the care of those patients that are deemed inoperable. So these are the folks who either after many, many attempts, and I've seen someone on their 11th repair who are deemed, we just can't help you anymore, I'm sorry, or your anatomy is very distorted and we just can't, we can't navigate around it. And so again, we need to keep in mind that the pathophys of obstetric fistula is very different, right? There's this field of ischemia. So even where the hole is not, all the tissue around the hole is often very abnormal. And so when you go to dissect those tissues and when you go to try to get those planes, it's almost impossible, which makes it, again, very different than the ones that happen in high-income countries like post, hysterectomy or radiation. Some of the radiations might be similar, but the post-hysterectomies are very, very different. And then finally, last but not least, is advocacy. So of course, advocacy is done to try to change some of the beliefs and the stigma around fistula and some of the attributable causes that we had alluded to earlier. There's been some pretty good work done in advocacy, but of course, there's still some room for improvement. One of the greatest success stories is that of community health workers. So this is Rashid, who's a community health worker through Fistula Care Plus in Uganda. And so the community health workers are usually folks from the area. They speak the local language, they know the people, they are familiar with customs and the belief system. And usually they are used to go out and do health messaging. Often it has to do with maternal health issues, fistula prevention, what are the signs of obstructed labor, when should you go to the hospital, and so on and so forth. The former fistula patients or fistula survivors have also done tremendous work in this. So this is Margaret, who lived with fistula for 13 years and then underwent a few repairs through UNFPA surgical camp ended up being dry. So folks like her, as well as Fiona, who is from Uganda, survived fistula, got repairs, and is now dry, is now studying to be a midwife. So folks like this have been able to really change attitudes in their respective communities. They've educated others about the cause of fistula, but even more than that, as living examples, they're able to show people that are living with fistula, oh, you can be cured and you can be dry. And then finally, the Hamlin Hospital in Ethiopia has implemented a brilliant model where they have a college of midwifery. So these midwives have sort of a return of service agreement. So when they graduate, they have to go back to their communities and do a certain period of time working there. And so, of course, they go into the community and they try to change misconceptions around fistula. They change stigma, but they also then are providing that antenatal and intrapartum care to address that first step, and that is prevention, to decrease the incidence of new cases. And then finally, of course, research underpins all of this, right? We need to know if the initiatives and the interventions that we're implementing are effective, what kind of gaps exist in the projects that we have, and so on and so forth. And so in understanding all of these complex issues in obstetric fistula care, for my own work, I sought to find the gaps and try to target these. And so my current work is three-pronged. So with respect to the surgery, as we've been saying, I just returned from Angola. And this is in my effort to hopefully address the backlog of cases and the need for fistula surgeons. I was graciously welcomed back by my friends, Dr. Steve Foster and Dr. Annalise Olson at CML, who I know from 9.5 years ago. Annalise is actually my very first fistula teacher. There I was also able to work with Dr. Fakad, who is from Ethiopia and the former director of Hamlin Fistula, and a brilliant surgical teacher. He's also a current FIGO fistula trainer. So I firmly believe that we never stop learning, even as staff people. And so I'll be returning next month for ongoing fistula training with them. The second prong in my work is that of capacity building. So I truly believe that the only way forward to ensure sustainable change is by investing in the future generation. And that is super important in terms of looking at safe antenatal and intrapartum care for generalists and just knowledge overall. So this is a photo of me with the interns after morning teaching every single morning at CML in Angola this past month. And these are the nurse midwives at Karanda Hospital in Zimbabwe when we were reviewing some of the obstetric emergencies. In the same vein, I'm a content consultant for the Essential Surgical Skills curriculum at the Global Surgery Lab out of UBC. This is a super exciting e-curriculum that has been developed in partnership with Médecins Sans Frontières. And it's in an effort to help strengthen non-surgeon physicians to provide basic knowledge to them, but also, surgical skills in managing both urgent and life-threatening conditions. This was successfully piloted in South Sudan, and we're looking at piloting in another location very shortly. And then finally, as the global health lead in our department at Mcmaster, my hope for our global health committee is that we can support our LMIC partners as we collaborate on some capacity building, but also some other projects. And in fact, we have some exciting endeavors coming down the pipe, but I think that's all that I'm allowed to say at this point about that. And then finally, research. So again, in terms of that theme of looking for gaps in our knowledge, I really believe that's where research fits into it. And specifically when it comes to research in low and middle income countries, I truly believe that those questions and those projects need to originate from the surgeons, healthcare providers, and the patients that are in the low and middle income countries. And so this project that I'm working on right now, which assesses the effect of schistosomiasis infection on the fistula repair outcomes, was an issue that the CML surgeons noticed. And so they asked me to take that on. Another project that I'm working on is a scoping review on fistula repair training and capacity building. So again, because I noticed a gap in the literature pertaining to how many cases, how many years, stratification of the data, I decided to go ahead with the scoping review to figure out if we could just get a bit more evidence behind what we do. And then I'm currently working on a survey of global surgery interest among Mcmaster trainees. with one of our excellent OB-GYN residents, Dr. Isabella Fan, who's on this call as well. So if you are at Mcmaster and you're a medical student or a resident, this may be coming to a session near you. And then finally, I am a principal investigator for UBC's Global Surgery Lab. So we've seen that obstetric fistula is unique in that a lack of access to surgery drives both its development as well as its persistence. So because there's a lack of or a delay in cesarean section, sometimes obstetric fistula forms because of obstructed labor. In addition, because of a lack of fistula surgeons or access to fistula care, many folks with existing fistula remain unrepaired and they sit there for 20, 30, 40 years. And so in conclusion, the work in obstetric fistula obviously is far from done, but it has been encouraging that in recent years, it's gained some traction and some attention in the global community. But as we've seen in the Millennium Development Goals, concerted global efforts and we can achieve endpoints collaboratively. So looking ahead, the road is winding for fistula care, but the hope is that one day folks like me that are involved in fistula work will have to find another line of work, and that hospitals like the one that predated the Waldorf will be able to close because there will be diminishing cases and no need for them. Obrigada. Thank you. That's all I have for you.
Thank you so much.
All right, Murshad, can I turn it over to you?
Sure. Yeah. So I don't have any questions in the chat that I can see. I don't know if anyone messaged you personally.
Let me just check. Hang on, I'm just changing my here. There is nothing in my chat. We do have the questions that people submitted upon registration.
I have a question.
Yeah, for sure.
Okay, great. So my name is Sarah Leah. So thank you, Dr. Chin, for speaking to us today. I didn't know much about obstetric fistulas, so thank you for that. I was really interested in the little tidbit that you left us about sort of family life versus, I know you don't want to get into it so much, but family life and global surgery and global health in general. I'm interested in knowing how you hope to bridge that gap, like in the future. You know, I know that you're doing your master's now and that you're like, how do you sort of separate your time between Canada and Angola and the other places you've been?
Yeah, that's a great question. And honestly, I will say that for the most part, like when trainees contact me, that's usually one of the main questions that they're asking.
Okay.
And even like, I'm going to say, even not trainees, like even, you know, fellow staff people at various career stages, that's always the, like, you know, the number one question. So I will say that we've always tried to bring our daughter. Obviously it makes for very expensive airfare. And obviously travel with a child is not easy. I'm not going to lie. Nevertheless, it's always been important to me to incorporate my family and also the duration of the trips that I'm on. They're just a little bit too long. Like I just did 1 month and that was the longest I've ever been away from home. And that was pretty tough from the family standpoint. So we do plan on bringing her. In terms of figuring out schooling and whatnot, like if we do end up long term, I know a lot of expats have looked at things like boarding schools, and there are some excellent boarding schools, depending on where you are, but that's obviously getting very like into the nitty gritty detail. So I can't say I have like a panacea for you to say that this is how it will for sure work, but it's sort of a trial and error depending on the opportunities and doors that open up. We have a few like strategies that we'll consider. But as of right now, like our daughter's in school here in Hamilton.
Right. Especially also when they're younger, it's like probably a little easier, you know, in terms of making things.
For sure. Yeah. Like, you know, when she was 2.5 on a compound, like there wasn't, you know, there wasn't like math and language and like, you know, all the usual academic things. Whether or not you have kids, if you remember back to your own academic life, right? Like there's growing responsibility as you advance through the years. Does that kind of answer your question?
Yeah, I mean, trial and error, I think, is the most sort of overarching thing that you said.
Yeah. I mean, I'm happy to talk more about it. I don't want to like, I could go
No,
on.
no, it's okay.
This is an area that I am very passionate about, but yeah, maybe we'll pause there, and then we can revisit it if we have more time, or you can always connect with me offline and we can talk in more detail.
Thank you.
I think I see a hand up.
Hi.
Hi.
My name is Ariel. That was a really amazing talk.
Thank you.
So my question is, I guess, along that vein as well, because you're involved in so many areas, surgery, research, how much of your time is spared between what? So how much time are you away versus teaching? And I guess they kind of all happen at the same time, but yeah.
Yeah, great question. So it's very busy. And I am the first person to try to dispel the myth of like being a superhero. Like we all have 24 hours in a day and we all have to work within those restrictions. Oftentimes it's just sort of like saying no to things or not yet and then timing them appropriately. Like Rashad was, saying, oh, I hope it's not a super busy time that you took on this talk. And it's just a matter of thinking like some of my master's deadlines or my clinical duties. So it's all a very like finely choreographed arrangement. Yeah, but I mean, I have had to learn how to say no to things or not yet and delay them. And I anticipate that's how it will be moving forward. It also helps, I will say, to have a team behind you. So for example, one of the research projects that I'm doing, right, is with Dr. Isabella Fan, who's on this call. So being able to, have some of that work distributed among people is also super helpful.
Okay, thank you.
You're welcome. I don't see other hands. So
There's some questions that people sent when they registered. If you want, we can go through a couple of them.
Sure.
So
the first, do you want to read them and then I can answer them? I have them here, but you can go ahead.
yeah, sure. If you want, you could answer some that you find more interesting for everyone, and then go for it.
Okay. Oh, sorry. I think the other thing, actually, before we launch into that, is we forgot to ask if the folks that just asked their questions were okay with that being recorded.
That's true. If I guess if you weren't okay, I can clip it out, Ariel
Okay.
and Sarah. But
Okay.
yeah, but otherwise, now you know. But also
Okay,
at the
Sarah.
beginning, we did say that it was recorded. So if ever there's a problem,
Okay.
just let me. I'll cut it
I
out.
think you have consent. Sarah and Ariel have given their consent to have the questions recorded.
Okay.
Go ahead with the question.
Yeah. So other than the questions I sent you last night, someone was wondering about the hospital in Angola. How is it staffed? Like, what is the organization like over there, particularly?
Do you have a sense? I know this was sent beforehand, so I don't even know if this person's here or if they're going to listen to the recording. How's it staffed healthcare wise? I'm assuming they're probably not.
Yeah. Yeah. I think that's what it was.
Yeah, so the background is that this hospital was founded by Dr. Steve Foster, who is on faculty at Mcmaster. He's a Canadian. He was like one of the first medical school graduates of Mcmaster, I want to say circa 1972, roughly. And so he has been there for like 40-ish years. During that time, he noticed, some gaps in the healthcare there, found a site, opened up this hospital around 2002. So he's kind of been the lead surgeon there. And then 12 years ago, they brought on Dr. Annalise Olson, who is an American general surgeon, who is one of the few general surgeons, I will say, that I know that has the surgical repertoire that is needed for that hospital. So basically, Annalise and Steve do like everything under the sun. They do the general surgery, obviously. They do the gynae, they do ENT, they do like thoracics, they do ped surgery, they're doing vascular, like they do everything. And they've both kind of pursued extra like, ad hoc training in all of these areas to be able to serve the population, because otherwise there's nobody else that can do the surgeries there. There are the government hospitals, and I'll refrain from commenting on that. And then otherwise, it's all nurses that are there. So the nurses will run the labor and delivery, which is a very small unit. They will run the ward, they run the emerge and the outpatient. And In the last 2 years, they've brought on about 7 interns. So these are fresh medical school grads. They've now finished 2 years of internships. They're equivalent to our family medicine grads. They were the ones pictured with me there on the capacity building slide. So they have been able to really help in terms of taking some of the outpatient volume, like the non-surgical volume, away from Annalise and Steve, so that they can focus on operating. But I will say that, like many low and middle income country settings, the pathology is advanced, the presentations are often very serious and quite acute. So it's an incredibly busy center, and hence my statements about when you try to do fistula care in that setting where you have competing priorities, it's quite difficult to, do it in that perfect paradigm.
Great. And Isabel, do you have a question?
I do. I was looking
You
for
go
the
for it.
raise a hand emoji. Thanks so much again, Dr. Chin, for sharing your story.
You're welcome.
Kind of relating to what you said, I had a question about just maintaining the skill sets that you acquire when you go abroad. Like, I imagine like you and with family and everything, you're limited to a certain time frame that you give yourself when you go on the trips to learn, like to gain more skills and repairing fistulas. Do you ever worry when you come back that because we don't really see those difficult pathologies here, about losing those skills, or like, when you're like over there and there's like really difficult cases and examples where you're talking about like rewiring the ureters to like the rectum and just like skills that maybe like if they were happening here, you would require like general surgery and urology to get involved. Just like how to maintain those skills.
Yeah, great question, Isabella. So I think it helps when you are starting at a staff level. When you have essentially like basic surgical understanding and, just like haptic feedback, and what tissues are supposed to feel like and what planes are supposed to feel like. And it's really hard to articulate that, but when you've like done it that many times, you just kind of know. And so I found that first learning fistula surgery, having that background was very helpful, because you just kind of intuitively know when to stop, or when it's going, or when you're like, oh, that just seems a little bit odd. So that really helped in terms of rapidly accumulating that expertise. But also like knowing what you don't know, which is actually more important, right? Like knowing when to safely stop. In terms of losing the skills, I mean, certainly. But at the same time, I think and this is the argument in fistula, in like the fistula world right now, is that in the hopes, or like as fistula cases are decreasing in, say, a country like Ethiopia, each surgeon is going to do fewer cases per month or per year. However, if you then incorporate those folks into, say, a urogynecology program, or they just take on lots of urogyne cases in their day-to-day practice, then they're maintaining those skills, even though it's not fistula per se, but they're doing, say, like anterior repairs, posterior repairs, vag hits. And so they're still facile, right, doing vaginal surgery, they're still dissecting things. And so those are transferable skills. Obviously, the gen surge, the urology, like core procedures, we just wouldn't do here because we have colleagues that are, more well-versed. So that obviously is a concern, but I'm not quite at mains pouch skill level yet. So I will get back to you when I get there.
Okay, that sounds good. Thanks so much.
You're welcome.
Otherwise, I think most questions have been answered. I guess
Yeah.
if anyone has a question, they can write in the chat or unmute. But one last question, maybe just to conclude, would be moving forward, what needs to be done to improve surgical care access to low and middle income countries, in your opinion?
That was a huge question when I was going through the questions that you sent me. I hope the person's here on the call. Now, of course, I've like said that they're never going to identify themselves. So honestly, I feel like that question more or less encompasses the entire crux of the like field of global surgery. And so I think what I list is not exhaustive. And we're obviously always keeping in mind that the surgery or the procedure itself, as we've seen from the example of fistula care, is not the only part, right? Surgical care is this huge, like holistic thing. And so I would say that there are about 5 top of list priorities. And that would be prevention. And I think that's applicable to like any, global surgery issue that you think of, or any surgical care access issue. 3 delays is another big one that's transferable to most conditions. Health infrastructure, and that can be anything. So if you think like from a trauma standpoint, the biggest thing for them is actually transportation and road safety, right? Like seat belts, lanes, enforcement of rules, that kind of thing. Also things like electrical grids. Again, with the trauma example, if you have well-lit streets, the trauma incidents go down. Internet access for, again, this is like all across the board. If the associate clinicians need to consult someone like a surgeon for assistance, if you have reliable internet access, that opens up all of that. It also opens up like all the articles online, various like video procedures like the Global Surgery Lab has done. The 4th thing is scaling up of training and sustainable capacity building for healthcare professionals. And then I think the 5th thing is policy change, which is obviously a huge one, but that's at every single level, because some of these issues just cannot be dealt with by healthcare providers alone. So, and we're talking like local level, municipal, national, regional, international.
All right, cool. So maybe some people have questions that they don't want to be recorded. So I guess we'll
Sure,
soon
you can stop
close up the
recording.
recording. Just before, I guess, if anyone wants to speak with you or contact you, how could they reach out?
Yeah, so I can put that slide back up. I am on social media, embarrassingly inactive on Twitter, but I will check. I'm on Instagram, and then Mcmaster folks probably can just find me through our directory. And I mean, if there are any questions for follow up, Rashad, if they contact you, you're welcome to forward my email address.
Okay.
I don't mind at all. So I'm happy to stop the recording if there are questions that people don't want on record, but there are also all those other questions. Do we want to answer them, or like, what do we want to do?
I found a lot of them were answered during the talk, but if there's any that you want to highlight, go ahead.
No, that's okay. If you feel like they were answered, that's fine. We can
Okay.
leave
All
it
right.
be.
So I'll just stop
Okay,
the
we can stop
recording.
recording.